At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome, and thank you to everybody for putting aside your allergies or whatever, maybe keeping you a little, like me, a little stuffy-headed, and attending to this episode of GLI Live today. My name is Donna R. I'm the founder and CEO of the Global Liver Institute. And today we'll be talking about an issue that's very close to our hearts, very high on the priority list for the Global Liver Institute since its inception, that of the liver health for veterans. And today I have with me none other than that great friend of and partner to GLI, Dr. Michael Fuchs, who is Chief of Gastroenterology and Liver Transplantation at the Richmond VA, which is one of just 7 liver transplant centers within the VA health system. Welcome, Dr. Fuchs.
Welcome to Donna.
Thank you so much. We have worked on so many different types of liver issues across the years because of the scale and scope of the VA. So maybe first let's start there so people appreciate how large the VA health system is and how many veterans are affected by some type of liver disease.
Sure. Let me first start off and make it clear that I'm not talking today on behalf of the government, my employer, but as a private person. So liver disease really is pretty common in veterans. Let's just be reminded, about a past disease that basically, is not really of that much concern anymore to the VA healthcare system, which is chronic hepatitis C. Considering how many patients we have treated in a very short period of time. This basically demonstrated that the VA healthcare system on a global scale really was able to cure the largest number of veterans with hepatitis C in a relatively short period of time. I also want to mention to the listeners that veterans with liver disease, may have the option to get disability if it is determined that their liver disease is related to their military service. But things have changed since we have cured so many patients with hepatitis C. We now shifted towards care for those that develop cirrhosis as a result of hepatitis C, liver cancer. The need for liver transplantation increased. We still have a significant amount of veterans that deal with alcohol-associated liver disease, but clearly over the last years, MASLD, or formerly NAFLD, non-alcoholic fatty liver disease, has become really the most common chronic liver disease globally. So not only in the veteran population, but globally. And we recently only could tell our patients that we can make changes in terms of their lifestyle. We didn't have a drug, so clearly, March 14 made really a profound change in how we have to deal with that large patient population. We're talking about probably 3.6 million veterans that have fatty liver disease. So this really will change how we have to operate and deal with that disease of that magnitude.
It certainly is a different, consideration now that there is an FDA-approved therapy. How have you been linking veterans to care, helping them identify their risk factors for fatty liver disease, and treating them to date? And so how will this change once a drug becomes available?
So, I mean, we were not blind over the last years when
Right.
seeing that this disease, is rising in prevalence. So we have really started to address that in a system-wide manner by developing, guidance documents for our providers in how to address uh, comorbidities often seen in patients with MASLD, particularly, diabetes, obesity, dyslipidemia. So we worked on this, giving out guidance to the field. And we also try to engage with primary care because that's where the vast majority of patients have their first contact and are seen longitudinally over time, to focus on uh, trying to identify patients that are potentially at risk to develop progressive liver disease. Now, this is a task that is challenging because we all know about workforce shortages in primary care, the limited time they have. And on the other hand, we also need to be mindful uh, by utilizing specialty care because we cannot just
Mhm.
refer every single patient to specialty care. So we have addressed, how we can, develop those referral pathways. I can tell on our own in our own institution, we have been pretty aggressive upfront for the last couple of years and basically offered assistance to primary care by taking on those patients, do risk stratification, and actually develop a metabolic interdisciplinary clinic to take advantage to basically manage those patients that clearly need more than just what the primary care physician usually is doing.
That's one of the things that we've seen consistently across our conversations with patients and physicians through multiple surveys, that the interdisciplinary clinic, bringing the different types of specialists, endocrinologists, cardiologists, primary care and hepatologists together to be able to see a patient and to treat them from all different sort of sides of that metabolic triangle or quadrangle, seem to be the most effective, and that seems typical of the sort of the cutting edge way that VA has approached all liver diseases, from your virtual tumor boards and liver cancer to the sort of universally treatment approach that you took to getting hepatitis C rates so low. So I'm not surprised that that
Yeah.
you would be at the forefront of this as well. What are some of the learnings from having those different disciplines working closer together, which is unusual. I mean, we need to see more of that, and there are some non-VA fatty liver disease clinics that have been put together, but would you encourage those, or how, what has been your takeaway of sort of why they work, and why people may want to consider constructing things a little differently?
I think that without having a kind of interdisciplinary approach, it will be very challenging to really make a difference for the individual patient. The interdisciplinary approach, will help you to much more individualize treatment for a patient, management of a patient, being really patient-centric. It will tear down, the silos each specialty and primary care are working in, because you have direct communication with other specialties. And there can be multiple settings how this can
Mhm.
be executed. There is certainly not one size fits all
Right.
because the availability of resources depends or varies significantly. Particularly within the VA, not every center has all the resources that we, for example, have. So we have to be really creative in building those kind of metabolic units, so to speak, based on local, circumstances of available resources. Now, the one thing that I also want to say is that it is really crucial moving forward that you get the buy-in from the administration,
Mm-hmm.
because you need support. You can't just do this all on your by yourself. You may need staff, you may need space, just to mention two things. And when you start rolling this out, you may have to do, or you likely have to do, corrective actions, modifications of your model all along.
Mm-hmm.
We are still modifying it, and I wonder if there will be a final, definite solution at some point that doesn't require, reacting to circumstances that we, cannot really fully, control.
Well, I think that, as we try to deliver that personalized care that you mentioned, putting together all the different pieces from the imaging to the endocrinology that may be needed for a particular patient, because every NASH patient is slightly different in their collection of concurrent diseases and their stage of severity of illness. And so this is unlike, hepatitis C in that way, that there's not just sort of a clear marker and, and a one, treatment that's sort of easily delivered. And it's not as clear cut. So this is much more complex, both in the patient and in the pathway or the clinical setting that needs to be put together to serve them. And so thank you for doing that. How are you, one of the things I'm most frequently asked is, how are hepatologists like you, specialists in the liver, having conversations with primary care to help them, be engaged without feeling overwhelmed, to either identify or to manage patients with fatty liver disease?
I mean, this is something that requires ongoing and constant interactions with primary care, because at least for what I observe, in the VA healthcare system, and it may not be different outside of the VA, is that there is also a significant turnover in terms of primary care providers. And so, you may have educated your current primary care, but once you're done, then there are already new new
Mhm.
providers have to
Mhm.
start all over. So it's basically like an ongoing process. And I don't have the ideal answer to this.
Mhm.
I mean, you could argue, well, we have regular meetings to update them and
Mhm.
remind them. But then, you often run into the issue that, the time is so limited, and it may not be feasible all the time. So what we need to do, I think, is to make it as easy as possible for primary
Mhm.
care. So when we talk about identifying patients that have fatty liver, at risk to progress to more advanced liver disease, giving them tools in their hands to do a kind of easy first, risk stratification. And even, when we talk about, as an example, FIB4
Mhm.
as a really not costly diagnostic tool,
Mhm.
then we need to somehow, make it available to primary care, that they don't have to pull out a calculator, type in different numbers, because this is a concern to them. And so we need to figure out how we can get this available in your electronic medical record system. And that's what the VA is trying to roll out at every
Mhm.
facility. And there are ways to do this. And I think we are on a good way to do this as a really first step to roll out something in our healthcare system wide. But it cannot stop there. because we all know that FIB4 alone is unlikely, or we know already the not a single test that allows us to further risk stratify, particularly if cost becomes an issue too. So we need to find out what second test can we offer, and what second test can we offer throughout the healthcare system, because I don't want to have a veteran in Richmond getting all things that he wants, and then somebody else in a more rural state doesn't have anything at all. So
Right.
we need to offer drugs, or give the veteran the same access to care. So we also have to look to make those risk stratifications feasible with the local conditions. And I don't see that there is a unique approach that, again, is dependent on resources available.
I have for a very long time just advised physicians to use what you have, whether that's an MRI or MRE, because of that, the lack of even diffusion of the diagnostics, whether that be, VCTE or elastography or MRI PFDD, which may be more sensitive, but are hard to come by. I was recently helping a patient try to find access to a particular type of imaging, and it was a lot of calling around. And sometimes if even people had the type of machine, they didn't use it very often, and so it wasn't in the forefront for them. So I think that there's work to do for even people who have these different types of imaging that can help them make a more precise diagnosis of disease severity, or who's an F2 versus an F3, for example, let alone who's cirrhotic and non, which is one of the most important things. To let them know that they may have the equipment in their health system somewhere, but it hasn't been highlighted, and we can start to use it more.
I think we have come really relatively far already, and the VA has has a relatively broad access to liver elastography compared to the private sector, but it's still not broad enough. But I'm hopeful that if we really utilize the newer technologies, that we will get relatively soon, and soon I mean probably maybe 2 to 3 years or 4 years, technology, as a kind of point of care technology that can be done even in the hand of a nurse, doesn't require a physician, that will replace some of the more costly, diagnostic tools that we are currently using. And that will open up, access to new drugs for sure.
Absolutely. We are part of a lot of different diagnostic development programs, and also encourage those outside the U.S. that are some of, as you said, are nurse led. And so the more that we can, support that appropriately at the patient need. Because even 2 years sounds like a very long time to my patient years. Even though I know in the the arc of diagnostic development, that's pretty short time, but for patients who are in need now, that sounds like forever. So we're going to do what we can to accelerate that. I want to ask about another technically complex process, and that's liver transplantation. This, April is Donate Life Month. For me, as a liver transplant recipient, every month is Donate Life Month. What are you seeing in liver transplantation in the VA? Is the path that people, or what drives people to need a transplant, has that been changing over time?
Yeah. So first of all, I think that the field has changed dramatically after eradication of hepatitis C in the VA, more or less. So we are now more dealing with alcoholic liver disease and fatty liver disease, as a reason why people progress to cirrhosis. So this has changed, and the demand for liver transplantation has gone up for sure. Now there is the capability to, have, or where you can send veterans outside of the VA. But if you look at all the metrics, care that the VA provides has usually a much higher quality. And so I think the focus is to better utilize for the veteran, the VA transplant centers. And the experience that we have is, we are seeing an increased flux of patients that are referred to our side. We are now there for 2 years in a row, the busiest liver transplant program in the VA. So we are now doing more than 40 liver transplants per year, and this we're probably hitting 50. This would obviously wouldn't be feasible with having a good surgical partner, which is in our case located at Virginia Commonwealth University. But we were able to add a living donor program also, which basically opens up significant opportunity, because you're not basically dependent on wait lists anymore. So we are trying to tap into this as much as possible. We also are more aggressive in terms of transplanting patients with alcohol use disorders. In the past, alcoholic hepatitis was almost everywhere a no-go. This has changed. So, but this all comes with a higher demand of care coordination, and particularly with alcoholic liver disease, there are a lot of resources that need to be utilized so that if you transplant those patients, that it really will be a success. And those with fatty liver disease have a large number of cardiovascular or renal comorbidities that we have to take care of. But I think we have shown that you can increase the numbers, and that's, I think, what the VA needs to start implementing and working towards as a healthcare system.
That's one of the things that we are, working on, expanding the types of peer support and other supports, both meeting the requirements for transplant. If one is coming in through an alcohol related liver disease, journey, and certainly how to be successful afterwards is a different sort of intensity, frequency, and type of support and services than for someone with PSC or something post transplant. And so we're trying to work with you to meet the moment so that those families and can have access as well and be successful post transplant as we see that they can be.
Yeah, it's also important that we make it very clear to our veteran patients what additional benefits they get if they are transplanted within the VA healthcare system, because that's often forgotten about. And when one is just looking for the most convenient way, if you may have a transplant center, 60 miles away, but they are doing only little transplant or very few transplants. We need to remind them there are coming travel benefits, and medication costs are lower, and so on. So we need to better communicate that to our veterans and also to the smaller facilities that refer those patients to us.
And those are huge. That issue of continuity of care, having the history before, and being able to connect all of that afterwards with those additional benefits, and certainly the role of medication access to adherence. I remember coming out of my transplant with like a fishing tackle box of 17 different medications, medications for the medications, and so. That's not to be underestimated, and so we'll definitely pledge to try to make people more aware of that and the veteran families that we have, both on our board and through our A3 program. I'm going to make sure to ask them more questions about how we can do a better job of sharing that knowledge and information, and making their experiences better known.
And
So,
state borders are not really that much of a barrier issue for the VA healthcare system. We can follow them through telemedicine. We are working with local VA facilities, so the opportunities are there. We just need to fully tap into them.
and that's huge too in this sort of post-emergency waiver environment, where a lot of the state, borders to medical care have been, put back up. And so I think that's, being able to receive care in ways that you don't have to drive hundreds of miles to, but can rely on the best place for you, and the best practitioners is fantastic. So is that part of the future of liver health? More technology, more telehealth, enhanced access? What would you like to see in the future of liver health for the VA?
Well, this is something I ask myself constantly. Where is the field going? And I don't have the final answer to this, but I can give you some thoughts where I would like to see things moving towards. And that is, one key aspect is we need to really move towards patient-centered care and individualized care. And so we no longer should accept that one size model fits all. So we need to work this. We have a very broad diversity of healthcare professionals, but in my opinion, they are not utilized to their best capabilities. So there is room for improvement there. We also need to consider that there are clear trends over the last years that continue to moving forward, and that we cannot ignore either. So we need to consider about workforce shortages, what we have available, what we will have available in the future. We cannot ignore that disruptive technologies have entered the healthcare sector, and they are not going away. They can be a great asset to patient care for the patient himself or herself, as well as for the provider. And patients have changed too. They are much more acting like consumers. They have their own mind, their choice, and we need to respond to that too. We cannot just dictate this is what you have to do, and this is the way how it is being done. So we really need to evaluate our care models completely, and then analyze them, and then not being afraid to make corrective actions to those. Because what we really, in my opinion, currently do is we'll take care of sick patients. We wait until they are sick, and then we'll start working to control the damage that had occurred. So real healthcare is starting much earlier, where you take care of the healthy person and prevent that he or she is developing a disease. So we really must invest upfront. I know this is easy said because it will be a significant investment in this healthcare system, and it may only be able to, if you build a kind of broad coalition between forward-thinking healthcare professionals, patients, advocates, support groups, to make a real bold move for a better healthcare system in the future. And maybe that will convince our representatives in government agencies that at this point of time are not forward thinking.
Well, we certainly believe in that. Our liver health is public health is meant to embrace that idea, and the policy frameworks that support that. So I will just end on sharing that wish for the future of liver health with you. And thank you for being with us today.
Thank you.
Please be sure to like this video, subscribe, And share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.